Lowering cholesterol doesn't stop heart attacks. I know, that sounds backwards. You've not heard that before, but I've seen it too many times. The LDL drops, the doctor smiles, the patient thinks they're safe, and then they have a heart attack. I'm talking about people who did everything right according to the guidelines or the recommendations of their doctor, who was just practicing the standard medicine that everybody else practices. The patient took the statin, they hit the number, and still ended up in the hospital with a heart attack. Why? Because the number isn't the real problem. Lowering it isn't always the solution. So in this video, I want to show you why heart attacks still happen, even with perfect cholesterol. What statins actually do, and what most people don't understand about statins. What most doctors don't understand about statins. How the system pressures doctors to prescribe them, and why the system pressures doctors to prescribe them, even when it may not help. What tests reveal your real heart attack risk, and how to protect yourself without blindly just chasing a simple number. This isn't about fear. It's not about blame. It's about seeing more clearly so that you can make smarter choices. Let's get started. Let me tell you about Mike's story. He was 62, retired, active, ate better than most people. He walked every morning. He cooked most of his meals at home. No major health problems. No medications, except for one. At a routine checkup, his LDL came back high. So his doctor gave him a statin. And that was it. No questions, no other tests, no discussion, just the pill. And sure enough, 6 months later, his number had dropped. His doctor smiled, looks great, keep doing what you're doing. So that's exactly what Mike did. He kept walking, he kept eating clean, and he kept taking the statin. But one morning, as he bent over to tie his shoes for that walk, he felt a sharp pain in his chest. He couldn't breathe right. He sat down, tried to breathe, and again, it sort of interfered. 30 minutes later, he was in the emergency room with a heart attack. When we spoke later, he said something I'll never forget. What he said was, "I just don't understand. My cholesterol was perfect. I did everything they told me to do." And he did. But the story he'd been told, the one so many people are told, was just not complete. Because here's what doctors are trained to do. See a high LDL cholesterol? Lower it. That's what the standard practice is. It's not what's causing this. It's not, is there inflammation in those arteries? It's not, is there plaque already building? Just lower the number, the cholesterol number. That's the job. Now, why? Because that's what insurance rewards. That's what keeps the EMR clean, the electronic medical record clean. That's what the insurance companies are looking at. That's what protects the doctor from liability, from lawsuits, from red flags, red tape. And when you've got 10 minutes per patient or less, it's faster, it's safer, it's easier to hand out that prescription for the statin and then move on to the next patient. That's not really good medical care. That's compliance with insurance companies and legal risks and a bunch of other stuff that has nothing to do with your medical care. That's a reflex prescription, and it's happening to millions of people every year. So let's go back to that question. If your cholesterol is under control, why do people still have heart attacks? The answer is this. LDL can only be just a part of the story. It's a signal, but not the root cause. The real problem is what's happening inside the artery wall. It's not that it's clogged. It's not a pipe. It's a living reactive surface that gets inflamed over time. That inflammation is what makes plaque dangerous. Plaque builds up slowly, layer by layer, inside the artery. It's not always big. And again, it's not always blocked. If it were, we could predict when a heart attack's going to happen. And everybody knows that we cannot. We can't. It's instability. And when that inflammation gets worse, that's when you get instability. And the plaque becomes weak and it can rupture. Eventually, the surface cracks open, just like a blister or a pimple under pressure. Now, your body sees that as damage, so it tries to seal it, to stop the bleeding. But here's the problem. It uses a patch that's both effective and dangerous. I'm talking about a clot. Clots are how your body stops bleeding. But in an artery, that clot can break off. It can block blood flow downstream in an instant. When blood stops flowing to the heart, that's a heart attack. And this isn't rare. It's not a theory. It's what's happening when you have a heart attack. Most heart attacks actually happen exactly that way. Now, here's the part that nobody talks about. Half the people who arrive at the hospital with a heart attack have a normal LDL. Normal. Let me say that again. Half the people coming in with a heart attack have a normal cholesterol, LDL under 100, some even under 70. Many of them are already on statins. And yes, if you've heard that right after a heart attack you can get some decrease in LDL, yes, that's true, but it's an academic point because it's not low enough to impact the overall level. Normal LDL levels are very common to find when people come in with a heart attack. A big study found that 64% of patients had LDL under 100, and almost 1 in 4 had LDL under 70. So yes, the number looked great, but they still had a heart attack. And we talked about getting that drop of LDL post-heart attack. It's only about 10%. That drop is not enough to impact these numbers. It's still in the, quote, safe zone. The risk was there all along. It just wasn't being measured. LDL was not a good measurement of heart attack risk because the system was focused on the wrong thing. Instead of checking for inflammation or testing for plaque, it was chasing LDL levels. And chasing the wrong target can give you a false sense of security. That's what happened to Mike. That's what happens to millions of people. Because the monster here isn't just the disease, the LDL level. It's the story we've been told about how to treat it. When Mike and I first talked, he was just a few weeks out of the hospital. He was still shaken and sore, a little frustrated, and a lot confused. He said, look, I followed the plan. I took the statin, I watched what I ate, I continued to walk, and my doctor said I was doing great. So why did I still end up in the hospital with a heart attack? He wasn't bitter so much. You could tell that. He just felt let down. And I understood that because I've seen it before, time and time again. A lot of people do what they're told, but what they're being told just isn't enough. I told him we weren't going to just try and lower his cholesterol anymore. We needed to look at what was really happening inside his body. So we started from the inside out with inflammation and not just the basics. We ran the full panel. His CRP, C-reactive protein, was elevated. That was the first clue. Then we checked myeloperoxidase, a marker of oxidative stress in the arteries. That came back high. We added Lp(PLA2), an enzyme that shows inflammation inside the vessel wall. That was elevated. And then we looked at his microalbumin creatinine ratio. It can show early signs of blood vessel damage. That result wasn't normal either. All of these pointed to one clear truth. His arteries weren't just vulnerable, they were under pressure. He had inflammation. So next we reviewed his calcium score. He had already done this test, and we brought the number in. We looked at it, and it wasn't really dangerously high, but it was too high for someone his age and lifestyle. So now we had evidence of both inflammation and plaque. Then we ran another test, a set of labs with looking at glucose and insulin. And that's when we found it. Mike had undiagnosed diabetes. No one had ever tested him for it properly. No one had explained what insulin resistance looks like before it shows up on a blood sugar test. But there it was, and it had been there for years. And this is what we see all the time. People coming back from the hospital with a heart attack, and they've got full-blown diabetes, and nobody ever looked. That's what had been slowly damaging his arteries, long before his LDL was ever a concern. So now we had the full story. This wasn't just a cholesterol issue. It was inflammation. It was metabolic disease. It was silent, and it was completely missed. But we actually had some good news, too. Now that we understood what was driving the risk, we could build a plan to address it directly and personally. Not a prescription for a number, a strategy for the person. And once Mike saw the whole picture, once he realized there was something he could actually do about it, you could feel it. He stopped bracing for the worst. He started believing that he had options. That was his turning point. Once we had Mike's full risk profile in front of us, we had to rethink everything he'd been told. He had followed the advice. His LDL had been low for years. He was taking a statin, just like they asked, and he still had a heart attack. So now the question was bigger. If statins work, why didn't they work for him? Well, let's talk about that. Statins absolutely do help in some people, especially in those with known plaque in their arteries. That includes people who've had a heart attack or stroke. I get a lot of criticism from some docs, for actually using statins. But this is why I do. I only use low-dose statins. There are some people that this helps with, and that would be people with known plaque in their arteries, people who've had a heart attack or stroke. And it includes people like Mike, who've never had an event, but have plaque in their arteries. And his was confirmed by a calcium score. That's what we call secondary prevention, because once plaque is there, the risk is real. Even if the numbers still look good and the evidence is clear, in people with known plaque, statins can reduce the risk of a future event. And here's where it gets a little bit more complicated, where the public often gets misled. You've probably heard that statins reduce heart attack risk by 30 or 40%. And it's true, but only as a relative number. Let me explain what I mean. Imagine 100 people with heart disease. Without statins, 10 of them might have a second heart attack. With statins, that number would drop to 7. That's 3 people helped, a 3% benefit when you look at the total population. But the statin makers will say a 30% risk reduction, because 3 is 30% of 10. Now, it sounds bigger, but again, it's not entirely the full picture. You'll hear David Diamond and Paul Mason and some of the other doctors talk about just that specific issue. So imagine you're healthy. You've never had a heart event. Your risk of a heart attack might be 2%. Statins only bring that down to 1.4%. So that's less than 1%, less than 1 out of 100. So when we talk about statins for primary prevention, meaning people who haven't had a heart event and don't have plaque, we're talking about very small benefits spread across huge groups. That doesn't mean statins are useless, but it does mean they're really not for everybody, and they shouldn't be handed out automatically. We haven't even talked about side effects yet. Let's start with muscle symptoms. There was a large meta-analysis. You remember that's the type of study where you look at multiple studies that were done on a specific problem. It's one of the better ways of looking at evidence. So this meta-analysis included thousands of patients, and it showed that statins cause muscle pain in about 7% more people than placebo. That works out to about 11 extra cases per 1,000 people in the first year. In most of those cases, the pain was mild, but it was real. So then there's blood sugar. Multiple studies show that statins raise the risk of developing new onset diabetes by about 9 to 13%. In practical terms, that means for every 3 heart attacks statins prevent, one person's going to develop diabetes as a side effect. That's a serious trade-off, especially if someone already has metabolic problems. And finally, there are cognitive effects, brain fog, memory issues. These are rare and usually reversible, but they're real. Even the FDA includes them in the official labeling. None of this means that statins are necessarily bad, but it does mean we need to use them carefully and within a proper context with somebody that has significant risk, not somebody that doesn't. So let's step back and look at how the system got to this point. Doctors are trained to lower LDL. That is the standard of practice. Now, you may ask, well, is that what the standards committee said to do? Not really. The guidelines written by those committees actually say it's a deeper process with a conversation with the patient about lifestyle, about other risks, about multiple things. But again, if you're seeing a patient at the average time that patients get these days, that's 7 minutes, by the way. If you're seeing a patient in 7 minutes, you don't have time for that kind of conversation. Now, insurance companies like looking at an LDL. It's simple and it's measurable. You can't measure how long a doctor talked to a patient, but you can easily track whether someone had a prescription written, and you can easily track what their LDL number was. You can track whether their LDL went from 130 to 90 or 70, and that's what insurance companies reward. So when you follow incentives instead of evidence, you stop seeing the full patient. You just see a number. And this actually leads to something that we don't talk about often, but something that's real. And it's true. Just ask doctors. In surveys, most doctors will say, no, I don't do this, but I know a lot of doctors that do. What's this? Money. Over 100,000 doctors in the U.S. have received something from companies that make statins. It might be a sponsored lunch. It might be a consulting fee. It might be more than that. Now, I'm not saying that your doctor is being bought. I'm not saying that. But I am saying the system is built to promote certain prescriptions. And statins are way up there on that list. They're one of the most profitable drug classes in the world. In the U.S. alone, sales have reached over $4 billion, with a B, dollars a year. There's a reason they're being pushed. So, yes, statins can help, but they're not magic, and they're not for everybody. The real mystery isn't just how they work. It's why we've been taught to rely on them so much and ask so little. And once you see that clearly, you stop thinking about just a number. You start thinking about the whole person. That's when the story actually starts to change. Now that we knew what was really going on with Mike, we could finally do something about it and not just try a different pill, but actually get to the root of the problem. This is where the real fight started. We didn't need a more aggressive prescription. We needed a smarter plan. So we went back to the basics, but with better tools, better focus, and better feedback. We started with sleep because most people don't realize how much poor sleep drives metabolic disease and inflammation. Mike had always considered himself a light sleeper, a poor sleeper. He woke up at 3 and 4 in the morning quite a bit. But when we looked closer, we saw a pattern. Late nights, screen time before bed, inconsistent hours. That was one of the first things we changed. He started winding down an hour before sleep. No screens, cooler room, dim lights, 7 to 8 hours a night consistently. After a few weeks, he noticed something. It was very simple. He didn't wake up exhausted anymore. He didn't have to use an alarm clock. And over time, his inflammation markers started improving. Next came food. We didn't put Mike on a trendy diet. We didn't count macros so much or eliminate entire food groups. We did something simpler and more effective. Less sugar, more fiber, real food, fewer ingredients in the food. He cut back on processed snacks. He cooked more at home. He started paying attention to how meals made him feel afterwards. And he actually started looking at the impact on his blood sugar. He lost 10 pounds without starving himself. And his CRP dropped by nearly a half. Then we focused on movement. At first, Mike was just walking 30 minutes a day, steady pace, outdoors when he could. Now, that made a difference, and it had made a difference prior to his event, especially for blood sugar, blood pressure, mindset, but he needed more. After he completed his cardiac rehab program, we added resistance training. First with just light weights, a lot of reps. Did some body weight exercises. Started using some machines. Again, not that intense, but just enough to start rebuilding muscle, rebuilding strength. Keep his metabolism active. Make those muscles metabolically healthy. Grow those mitochondria because that's what he was missing. And then we started introducing short bursts of higher intensity interval work, brief spikes of effort followed by recovery. This wasn't go hard or go home and exhaust yourself. It was structured, gradual, and safe, especially after his heart attack event. The combination of cardio, resistance, and intervals gave Mike exactly what he needed. A stronger heart, better blood vessels, better mitochondria in his muscles, and again, better capillaries, those microscopic vessels in his muscles, because that is where his insulin receptors lived, and his diabetes had been decimating those capillaries. So again, he had a stronger heart, stronger body, better blood vessels, and now he was developing a sense of confidence that he had not felt in years. Next came stress, not in a big dramatic way, but in the daily, quiet management, the kind of management that lingers in the background. Mike had never learned how to relax intentionally. He worked hard his whole life, and after retirement, he carried that tension around, even without realizing it. So we worked on small shifts, a few minutes of deep breathing every day, time outside, deliberate breaks, regular conversations with people who made him feel calmed, not stressed. Over time, he noticed something surprising. He stopped feeling like he was on edge all the time. And his blood pressure, guess what? That came down. Now, even with all of those changes, Mike's inflammation did not drop to zero. That's not a failure, it's reality. So we added some support. For inflammation, I often recommend omega-3 fatty acids. After years of research, I finally developed a formula I trust. It's called Omega. It's one of the most effective natural ways I've seen to help cool the fire inside the arteries. It's easy to take and powerful when combined with the right habits. You can learn more in the link that we've included in the description of this video. Back to the story. In Mike's case, we also used a low-dose statin, not to crush his LDL level in his blood, but to help stabilize plaque and support inflammation control. He wasn't taking it daily, just a few times a week, based on his numbers, his tolerance, and his goals. And we monitored everything: CRP, C-reactive protein, calcium score, CIMT, blood pressure, glucose, insulin, because the goal wasn't perfection, it was progress. And most of all, clarity. That's what the fight really looked like. It wasn't about doing everything all at once. It was about doing the right things, one step at a time, with purpose. So, as I mentioned, we did low-dose statin. That's like 5 milligrams of rosuvastatin per day or less. With rosuvastatin, you can do it once a week. It's better to do it twice or 3 times a week, and a lot of people take it daily. I used to take it daily. I'm currently at about 3 times per week. The other statin that we'll use is pitavastatin. It's a little bit more expensive, so insurance companies will push back unless you've already tried rosuvastatin. With pitavastatin, it's naturally a lower dose statin, 1, 2, sometimes 4 milligrams. Don't really use atorvastatin. That's the old, most popular, still most often used. The reason we don't use atorvastatin, it helps with LDL. It's good at lowering that LDL level, but it doesn't help quite as much with inflammation. And most people with this problem have metabolic disease. It also doesn't help as well for females. So we just skip over that and use a nice, easy, generic, inexpensive rosuvastatin, up to 7 times a week, low dose, but more often, 2 to 4 times a week. So Mike was now relaxed. He had a purpose. He felt confident. He was starting to turn things around. And most of my patients do the same thing. You see, it had been a year since Mike's heart attack. That was our 4th follow-up. He walked in more relaxed than I'd ever seen him. He was lighter on his feet, clearer in his eyes. He sat down, smiled, and said, "I feel better now than I did in my 50s and before my heart attack." And he meant it. Not in a forced, I guess this is helping kind of way. He meant it. He was very relaxed, but like someone who finally understood his own body. The changes weren't that extreme. He had lost a good bit of weight overall, over 10 pounds. These changes were steady, honest, and real. He'd lost weight, yes, but more importantly, he was sleeping through the night. He had energy again. He wasn't living in fear anymore. He wasn't pumped up on cortisol anymore. His labs told all this story. The C-reactive protein, down. LPPLA2, down. Blood pressure, steady and down a little bit. Glucose, insulin, finally in normal ranges. Nothing dramatic, just quiet, steady progress. The kind that holds. And you know what stuck with me? He didn't come in asking, "How's my LDL?" He came in asking, "How's my inflammation? Am I still headed in the right direction? Because I feel like it. My weight's down, my blood pressure's down, I feel good, I'm sleeping well." And that's when I knew he had crossed over from patient to partner. He still had plaque. We saw it on his last scan. But now he understood what that meant and what to do about it. He was still on a low-dose statin, 5 milligrams twice a week. Not because of some rule, but because it fit his risk and his goals. It was a choice, not a reflex, and it was working. He was still walking every morning, lifting weights twice a week, still doing short intervals of high-intensity work, and he felt good. His meals were simple. He had cut carbs. His routine was boring in the best way possible. He liked it that way. He told me, for the first time in a long time, I feel like I'm just not fighting my body anymore. I'm working with it. That's what happens when you treat the right problem. So if you feel like the system has failed you and you need help, call us, 859-721-1414. That's 859-721-1414. And ask about our coaching program. You can also become a patient. Our team will be happy to guide you through the right testing, the treatment, and support. Back to the story, because the people who change their health, they don't do it with one big breakthrough. They do it with steady, incremental changes, small changes. They do it with clarity. And that's what Mike found. And that's what I want for you. Mike's story shows what happens when we stop chasing a number and start asking better questions. Not every patient fits the same mold. Some people are born with a condition called familial hypercholesterolemia. Pardon the big geeky word. Let's just call it FH. It's genetic, and these people produce too much LDL cholesterol. Technically, they actually just never break down their LDL cholesterol very well, so it just climbs higher and higher. No matter how well they eat, how much they exercise, or how disciplined their lifestyle is. I see patients like this all the time, and I have for years, in their 40s, 50s, active, never smoked, and their LDL still over 180, 200, 300. In fact, if your LDL is over 180 and you're not on a low-carb diet, it's a 80 to 90% probability that you have FH. It's about 1 in 400 people. Now, when these people go to see a doctor who doesn't know this, is not aware of it, the doctor often says, look, you're just not trying hard enough. You need to lose more weight. You need to exercise more. You need to eat differently. And that's not just wrong. It's dangerous. In these cases, statins and sometimes low-dose aspirin can play an important role, not as a quick fix, but as part of a bigger plan when they have plaque that includes inflammation control and real monitoring. Then there's the other side of the curve. People who go low carb improve their metabolic health and drop their inflammation, and their LDL still shoots up. These are known as lean mass hyperresponders, or let's just say LMHR. Again, sorry about the geeky words. These people are usually lean. That's why it's called lean mass. They're fit, they're insulin sensitive, and when their LDL jumps, it's not because of damage. It's just because of the challenges on their metabolism. Their metabolism goes from carb-driven to fat-driven. It's often just how their body transports fat on a low-carb diet. And still, that kind of shift raises questions and sometimes fear. I have patients call me so many times saying, I went low carb. My LDL shot way up. My cholesterol got way high. My doctor told me I was killing myself. Now, the key here isn't to react blindly. It's to look deeper. If a lean mass hyperresponder has no plaque, no inflammation, and stable markers, high LDL doesn't always mean high risk. You know those standards committees, the guys that come up with the original interpretations of the guidelines? They started saying this a few years ago, too. If you don't have plaque, you don't need statins. Now, if they do have plaque, even just a little, they may benefit from a low-dose statin to stabilize that plaque, and sometimes low-dose aspirin as well, depending on their history and their risk profile. This isn't guesswork, it's risk management, grounded in testing and personalized care and an understanding of risk. So whether someone has inherited cholesterol problems that won't budge, or a lifestyle-driven LDL spike that no one prepared them for, the answer isn't fear. It's context. It's understanding. It's the right testing. And it's a plan that fits the person, not just the paper and not just a simple number. That's the kind of medicine I believe in. And again, I've said it before, I'll say it again. Those standards committees, that's the kind of medicine they actually recommend. It's what more people deserve. Now that you've seen what's really behind the statin story, there's something else you need to understand. We've been told the wrong story about cholesterol. Find out the right story. Click this video right here.